Hi, everyone. Welcome. Welcome to our special episode from the ISHRS of live stream with our very esteemed guest, Dr. Tosti. I'm Dr. Jennifer Krejci. I am a board certified dermatologist. I run the Limmer Hair Transplant Center in San Antonio, Texas. And we're here to share with you some information about female pattern hair loss today. Dr. Tosti is the president of the American Hair Research Society. She is a professor of dermatology at the University of Miami. She has written books for both consumers and doctors. She, according to PubMed, has over 800 publications. Dr. Tosti, do you know how many of those are in hair loss?
Yeah, I would say half at least.
So she's the expert. She is our mentor in many ways, and so we're so happy she's here to join with us. She will be also joined by my colleague, Dr. Paul Cotterill. He's coming to us from Toronto, Canada, in his clinic, Cotterill Hair Restoration. And then we have Dr. Nicole Rogers, my friend and colleague in New Orleans, just down the road from Texas. Yeah. And she has the Hair Restoration of the South and has been doing hair exclusively for many years now. So I'm going to let you each say a little something about yourselves. Dr. Tosti, would you like to start?
I've been studying and working on hair for more than 30 years. And so I think I know pretty much what patients feel. And I think this is a very difficult problem to cope with. And so I'd be happy to answer all your questions.
Dr. Cotterill.
Well, thank you, Jennifer. I'm board certified in hair restoration surgery. My clinic's in Toronto, Canada, as you were saying, and I've been practicing specifically hair transplantation for over 30 years. So I see a lot of women and men that both suffer from scalp hair loss.
Wonderful. Loads of experience to share with us today.
And I actually did general dermatology for 8 years before I switched over to only focusing on hair loss. And I've been just doing that for the last almost 5 years. And, it's definitely a challenge. I think every new patient we see, has their own different situation and obviously different condition. And I think my favorite part about treating hair loss is just playing Sherlock Holmes and trying to get to the bottom of things and figure out, what is going on for them.
That is so important, and because I bet a lot of people come to all of you as for second opinions after they've sought help with other people. So we're so happy that we've got the experts here to put our brains together. I think a lot of us have seen information about hair loss with COVID and are you losing your hair because of stress? And a lot of that is telogen effluvium or stress-induced hair loss. But today we know that most of our women patients are suffering from androgenetic alopecia or female pattern hair loss. So that's really the focus of our talk today. Dr. Tosti, when you're seeing a patient who has hair loss, other than the normal history taking, what do you ask specifically for your females with hair loss?
I really ask about periods, if they have children, they don't have children. I try to understand if the hormonal side is okay. And nowadays, a lot of women take supplements that contain hormones. They are using implants with maybe testosterone, and they don't tell you because they think this is something normal. Instead, it's something that can be very bad for hair loss. And also, I ask a lot about hormonal supplementation like bioidenticals, because people have the idea that bioidenticals, since they are not chemicals, that don't cause any harm. And so that's a part that I really focus on. And I ask a lot also on nutrition, because I believe what you eat is very important and may also be part of the problem. And I ask about medications, but that's maybe a normal history. And I ask specifically new women about history of breast cancer, because this is important for the treatment I may give them, or history of heart disorders, again, because this may be important for the treatment. And I ask about exercise, because there are some type of exercise that requires a special supplementation. I spend a lot of time with them in questions. It's not something that can be done in 5 minutes. I listen to the patient first, but then I try to understand what they may do that is wrong.
I think that we can all agree that hair loss patients cannot be done quickly, right? Dr. Cotterill, do you have any tricks or special questions you ask?
Well, when I see a patient, as you say, they've been often referred to me for hair restoration surgery. And so I want to be very careful in assessing the patient to make sure that they are appropriate for a hair restoration surgery. With female pattern hair loss, it's the great mimicker in terms of generalized scalp hair shedding. We talked about telogen and effluvium, which is a long-term for short-term shedding because of the specific cause, and that type of problem wouldn't be addressed with surgery. So a really good history with the patient, asking how long has the hair loss been going on for? Has it been going on for 6 months? Then I'd ask, well, what happened 7 months ago? If it's been going on for 10 years, then that makes me think that it's more of a female pattern hair loss concern. So just as Dr. Tosti was saying, it's something that you need to ask a lot of questions, be patient, let the patient tell you a little bit about themselves. You want to look at the family history as well, is important in terms of determining if it's female pattern hair loss. And then certainly what medications are they on? And then looking at the scalp, of course, is very important, which I'm sure we'll be talking more about.
Yeah, Nicole, Dr. Rogers, anything to add?
Sure. So I've kind of trained all my staff to ask as part of the intake anyone if they're having itching, burning, or tenderness, because I feel like that can really help pick up, conditions like central centrifugal cicatricial alopecia, lichen planopilaris, frontal fibrosing alopecia, which, as Dr. Cotterill was saying, are not necessarily things that we would want to transplant until we at least knew what we were getting into and tried to control their, inflammation medically first.
Would you all agree that a lot of female patients have maybe a combination of factors contributing to their hair loss?
I certainly would agree. Certainly in these times of COVID, you can have more stress related hair loss in combination with female pattern hair loss. And a very large percentage of patients that do have female pattern hair loss also have ongoing shedding because of other factors that are exacerbating.
Yes.
Any cause of telogen effluvium is going to worsen androgen female pattern hair loss. And that's what I explain my patients all the time. So, of course, stress will worsen it, as well as many other factors. So it's important to explain this to the patient, because sometimes they think, okay, telogen effluvium is going to recover by itself. But instead, this is something that is going to make female pattern hair loss worse every time. So it's very important.
And I want to come back to you in a minute, Dr. Tosti, and talk about, because you had mentioned diet, that it was a part of your question. But my next question is, so then once you've gotten the history and you've made your diagnosis, or you're trying to make the diagnosis, what are your favorite tools or tests, or do you have a specific list that you do on all your female patients? Dr. Tosti?
What I do is trichoscopy. So I developed trichoscopy, which is the use of the dermatoscope on the scalp. And in this way, you can see the scalp very, very close, and you can immediately distinguish female pattern hair loss from telogen effluvium or from scarring alopecia, because the pattern that you see at trichoscopy is different. So I really believe that without trichoscopy is like looking at the patient without eyeglasses. And I think we need to use this very simple instrument for all our patients. So that's a very important part of my exam. And of course, I also check the shedding with the pull test. I check if the hair has some breakage with other tests. And now I use sometimes the hair check, which is a test that can assess the number and the density of hair and the thickness of hair. So there are several tests that I believe patients should have also for the follow-up, because you give a treatment, you have to understand if this treatment is working. And so this test should be done in the beginning and for following up the patients.
We do have a question from Dr. Maghrabi. Hi, Shady. Thanks for watching with us. And he wants to know what you think are the most specific hormonal blood tests for women with female pattern hair loss, and if there's a certain time in the menstrual cycle when you would order these.
I usually, if I think there is a problem, I refer to an endocrinologist. But basically, what I would order, if there is no possibility, is total testosterone, the sexual hormone binding globulin. And I think these are the most important because the ratio gives you the free androgen index, which is very important to understand if there is hyperandrogenism. And this test you can do at any time of the menstrual cycle.
I would say when I see patients, in terms of doing hormonal blood tests, I think again the history and physical is very important. If they are explaining of other signs or symptoms of an elevated male hormone, such as increase in hair growth of the face or very oily skin or lowering of the voice, those are masculinizing signs which make me think of doing hormonal blood tests. I don't normally do a hormonal profile in most women. I'll do other common blood tests, but certainly the hormonal blood tests I will do if I have a suspicion of an elevated male hormone. And if I do have that suspicion, then again, I would refer to an endocrinologist.
How about you, Dr. Rogers? Do you have a certain lab panel that you order?
Mm-hmm. So I really don't order hormones in women just because, like, everything I've seen in the medical literature is, unless there is a specific clinical sign of hyperandrogenism, most women with inherited female pattern hair loss have normal hormones. So I'll usually, if they're having shedding in addition to that gradual thinning that goes with female pattern hair loss, I will go ahead and check vitamin D levels. I'll check zinc levels. I'll check ferritin, iron, TIBC, and then I'll also check a thyroid, a TSH in particular, if no one else has checked that.
Yeah, I do all those too. I'm glad you mentioned those. I find so much vitamin D deficiency in patients these days.
Mm-hmm.
And on a follow-up to the testosterone, you mentioned the pellets and various hormone therapies that women are taking, and sometimes they forget to mention them or they don't think this is a medication. And I've seen women that are being followed by a physician for their hormone therapy, and sometimes their testosterone is over 100, over 200. And if that may not be the only reason their hair is falling out, but it certainly isn't helping. We have another question from Dr. El Maghrabi, and he would like to know, Dr. Tosti, which brand of dermatoscope or trichoscope that you recommend.
I don't recommend any specific brand. I believe all of them are good. I suggest to buy a dermatoscope that can be attached to the iPhone. Most of them now can be attached, because I believe that taking pictures is very, very important also to explain the disease to the patient, because this is absolutely important to have a good compliance. Because patients come to see us and they believe that we are going to make a lot of new hair grow back. This can be fast. Instead, they have to understand, for instance, in female pattern hair loss, that we need to thicken the hair that is already there and require months. And so that's, I think, a very important thing to show the patient, because in this way, they don't come back after 1 month saying, I don't see anything changed.
Now, do you have a really elaborate system because you're associated with so much research and the university there?
Yes. I use a video dermatoscope, and this is called photo finder system. And of course, with this, I can also compare the global photography and verify if there is an improvement. So I use this complicated and expensive. But I believe that any simple dermatoscope is useful. I develop, now trichoscopy. So with teledermatology, I develop a way to have patients taking the pictures themselves and then share with me in the screen during the visit. And in this way, you can really, because in teledermatology it can be very difficult to see, to say, this is telogen effluvium, this is scarring alopecia. And so I developed this teletrichology.
Well, that's wonderful. I find that dermatology in general is very hard to do through telemedicine, and hair loss is even more difficult because you lose out so much detail. I was just going to demonstrate. This is the dermatoscope I use in my clinic, and it doesn't attach to my phone, but I've gotten pretty good with, balancing out. And, if this wouldn't be something a patient would buy, but certainly I find it handy in my clinic for dermatoscope or trichoscopy. Dr. Cotterill, Dr. Rogers, do you use trichoscopy?
I use a dermatoscope attached to my iPhone. And additionally, I think good photograph assessment just with a regular camera with different positions at a standard distance are very key for follow-up, again, to show the patients if there's a progress as well.
Yeah.
I'm going to show you the device that I use.
Oh, great.
Okay, it's called a ProScope. And what's fun is that, I don't know if you can see this here. It's attached to a cord, which is attached to a television.
Oh, sure.
So
can we see your hair? Are we going to see it?
If it won't gross you out.
Oh, I think our viewers would love to see your beautiful roots.
I'm overdue for highlights.
That was not a stab at your highlights. You look beautiful, Dr. Rogers.
So here's the screen. So you can see here. What I love about this particular setup is just that my patients can then see it with me.
Yeah, I bet they love that.
That's great.
So here's the patient view. We're sitting in an exam chair here, and then looking at the TV screen like that.
Oh, that's a great setup.
Yeah, it's kind of fun.
Yeah. I usually end up taking the photos with a tablet and letting the patients see them after I've taken the picture. So mine's not live, but I think that's a really nice way. Let's move on to treatment. We'll start with Dr. Tosti. How do you like to treat female pattern hair loss, or what's your first line therapies?
So I really believe that topical minoxidil is very, very important, and topical minoxidil should be part of the treatment. And so I always prescribe topical minoxidil, and I like the 2% solution for women more than the 5% solution.
Really?
I never use the 5% solution. Sometimes I use the foam if they don't have time to apply the 2% solution twice a day. So I really explain them how to apply. So I spend the time to explain how to apply and to make it clear that this is a kind of commitment and I have to be very consistent. And what women always ask, they say, I don't want to start a treatment. I read that once you start, you have to do that for life. And that's very important at that time to explain that unfortunately, it's the disease that is chronic and they're going to have the disease for life. And so they need to treat the disease. And even if they have a hair transplant, they still need to treat the disease to prevent that it worsen after the transplant. So that's a very important part, again, explaining, because it's important. Then I utilize oral minoxidil a lot nowadays. I may utilize finasteride, dutasteride, spironolactone only if there are signs of hyperandrogenism. I started using bicalutamide recently, and I have a quite good results again in women with acne, seborrhea, and other signs of excessive androgens. And then, I like to do PRP, microneedling procedures, but those in addition. I never just do PRP. And also the light. I like the light when there is inflammation, but not just the light. I try to combine. I believe the secret is combining.
When you say light, do you mean eczema or do you mean like the low-level laser devices that are
I
available?
mean the low laser level device.
I'm glad you mentioned that about the PRP, because I think it gets advertised a lot and probably oversold that it's the miracle cure for hair loss, but you just said you really don't use it as monotherapy or single therapy.
No, I don't. And I believe that, patients have wrong expectations. Yes, because it's sold in a wrong way. And so they see pictures of it, improvements
Amazing.
that are impossible. Yes, that you can just have with a transplant, and saying that was at the PRP. So it's a difficult.
Good question, Dr. Tosti. What dose of bicalutamide are you using, and how are you dosing? How are you prescribing that?
I prescribed usually 50 milligram every other day because that's the lowest dose that is on available.
Mhm.
And you have to check liver, maybe after 3 weeks. Usually, I never saw big problems, but you may see elevated liver enzyme in some patients. It's not like flutamide. I never use flutamide because of liver damage. Bicalutamide, if the patient is healthy, usually these are young women.
There's a question from our audience again here. So thank you guys for sending in your questions. I'm trying to get through all of them. The question is, we don't have a long-term study on low-dose minoxidil for female pattern hair loss. How do you think about the use of the dosage and the side effects? Dr. Tosti, you mentioned oral minoxidil.
Mhm.
How do you use it in your clinic?
We just published a multi-center study on side effects. It was just published on the JAD, and from all hair clinics, several hair clinics all around the world, and we didn't have any serious side effects. I usually use zero point 0.6 milligram in women, so I start with a quarter of the medication on the market, the 2.5 milligram medication, and I start with 1.25 in men. You have to be very careful if you compound the oral minoxidil, because I had the terrible experiences. So you have to use only one now I only use one pharmacy. I trust they know what I'm prescribing, but I had a patient who received 50 milligram instead of 0.5.
Oh
Okay,
no.
and he was hospitalized, and so
Oh
very
no.
careful in compounding. Try to use the medication that is on the market as much as you can, except for special cases.
Yeah.
And
Most
what do
of
you,
my patients have been able to just get it at a regular pharmacy. Like, I don't feel like we need to
No,
compound it.
it depends, because the regular pharmacy just have the 2.5. So
Right.
you can cut the 2.5. But if you want to go really low, like 0.25, for instance, which is what has been published first, and that the one that may be effective without causing many side effects, you have to compound. But then when you compound, you really have to trust the pharmacist. So you have to speak with the pharmacy and be sure it's the same person, because they don't know that we use oral minoxidil at these very low dose.
I've been using more oral minoxidil in my clinic as well. And if patients find it very convenient, it's cost effective. it doesn't goop up their hair, so cosmesis is good. And the only real complaints I hear once in a while when I'm asking in follow-up is, maybe they're noticing a little bit more fuzz on their face or a few more hairs on their lip. And a lot of times these women are already waxing or treating facial hair already. So I haven't found it to be a big problem with hair growth. And I think that's sometimes the biggest worry is the extra hair growth on the body that patients may hear about. Dr. Rogers, have you had experience with that, or Dr. Cotterill?
Well, I haven't seen really a much higher percentage of hair growth on the body with the oral as opposed to the topical. So you still have to watch out for it, but I don't feel it really is that much higher percentage.
And so was there anything, Dr. Rogers, that you treat your patients with that we haven't mentioned already?
Well, finasteride, 5 milligrams is very helpful in postmenopausal females, or, if they've had their tubes tied or if their partners have had a vasectomy, just so they won't get pregnant. I also like dutasteride, for women who've maybe plateaued after 3 to 5 years on the finasteride. And spironolactone is wonderful. You can do that anywhere from 50 to 200 milligrams daily. I like that for my premenopausal females because of what Dr. Tosti was saying. It can also help with things like acne and unwanted facial hair.
I also look at, we talked about before with regards to iron and ferritin levels. There's several studies that have pointed to minoxidil working better with adequate ferritin stores. And I often find that women have a low-end normal ferritin, which is not flagged as being abnormal, but I consider it hair anemic. And I think that that's something that we can work on, which is simple enough to do with women, is to give them an iron replacement if appropriate.
Well, since several of us are coming from the perspective of hair restoration, I would, and Dr. Tosti, you're primarily medical dermatologist. How do you feel that hair restoration fits in to women suffering from female pattern hair loss?
I always check if it's not so diffuse, because the problem with women is that they often have a very diffuse hair loss, that and so they are not good candidate for hair restoration. But of course, I believe hair restoration, if possible, plays a big role, because it's the only thing that can make the patient really happy. Okay. But we have to be careful again, because sometimes they expect to have results when the situation is too diffuse and not good for this type of treatment. So again, indications depends on patients.
Dr. Cotterill, tell us what your thoughts on hair restoration for
as
female.
well as as Dr. Tosti was saying, if it's a generalized scalp hair loss, you have to be very careful, because you won't see an additive gain if you're taking hair that's thinning throughout the scalp. If it's more frontal thinning, then they may be appropriate. I think setting the expectation level with women is very important. Men are happy with almost anything you could put up there, whereas women are supposed to have full heads of thick hair at all ages. So if they come in with high expectations, you've got to be very careful about what you can do with hair restoration. So you have to pick your patients carefully. And that's, again, I think where the dermatoscope, looking at the percentage of terminal and miniaturizing hairs at the back compared to the front, are come in very handy in assessing a patient as a candidate for hair restoration. And yes, so again, expectations are key. You want to do small areas, maybe more at the front where they can see the benefit, and pick your patients carefully.
That sounds good. Dr. Rogers, can you estimate, like, of the consultations you see for females who are, probably coming to you for hair restoration, what percentage of them would you say are candidates, or how does it fit into your practice?
I would say more of them are candidates than are actually interested in getting the surgery. Do you find that?
I feel like it's the opposite. I feel like I have women that, look like me and you and say, like, I'm losing hair. I need a hair transplant, and I have to talk them out of it so many times. But maybe I just have a different population seeking me out.
Yeah, I find most patients, if they can do a medical option first, or at least the women, they'd rather. and men are kind of more interested in just solve the problem. Let me have a transplant. Let me be done with it,
I want to address the audience here before we wrap up, because we're almost at 30 minutes, and I've really enjoyed everybody's contributions. Dr. Tosti, you mentioned microneedling, and we have a question about using injections of dutasteride or topical dutasteride and mesotherapy. Do you have any experience with that or any thoughts on that?
So I practice also in Europe. I have an office in Bologna, Italy, where I go and practice, and I use a lot mesotherapy in Italy, but it's not approved by FDA. So I don't use mesotherapy in the United States. And I think it's effective. So mesotherapy with dutasteride is effective. And there are data also with microneedling and dutasteride. You have to be very careful if you do that, to buy the correct solution, because I saw a case of silicone granuloma of the scalp, because the microneedling solution that has silicone inside was utilized for mesotherapy. Okay, so you have to know what you do. And I don't think it's a good idea to do in the US, because this is not FDA approved.
Okay. Dr. Rogers, are you doing any topical or injections of dutasteride or other solutions?
No.
Dr. Cotterill? Yeah.
No.
I'm not either, so I can't really speak to that. But I'm glad you have some experience you can share from Italy with us. That's helpful. Maybe if since you say you are finding it helpful, maybe we'll have some FDA approved therapies here. Is that anything you're working on in your research right now?
No, I'm not doing a study for that, because that's something, it's a very long study. And I don't use the mesotherapy as monotherapy. I add the mesotherapy to other treatments when the patients do not respond well to treatment. So it will be impossible for me to provide data for approval of that.
I don't want to leave out. Do you have a book I think that consumers could possibly
Yes, I have
look
a
up?
book for consumers. It's called Hair Facts. You can find on Amazon. So these are everything you wanted to know about hair loss and hair care. It's
Is
like
that geared
questions
for?
and answers. That's why from my everyday question from the patients, I made the answer and I wrote a book.
Oh, I'm so glad to know. Would that be for men or women? Is it for either audience?
Yes, it's for everybody. It's very simple. Yes, it's not a scientific. It's a scientific, but it's a simple book.
I think I want to add one more thing, or ask you all about hair products or hair care or hair grooming. Is there any tips that you want to make sure that patients hear, like things to avoid, things to do to improve the health of their hair? Dr. Tosti?
I think this is very, very important, because the overall beauty also depends on the hair quality. So if you grow hair and then you damage the hair that is there, the quality of the hair is going to be bad. So I always advise about shampooing, advise about what to avoid, like friction, because sometimes patients don't understand that friction can be so bad for their hair. And now, all the young people do the ponytail with the hair. They don't use an elastic. They just use the hair, and this is very, very damaging. So I try to teach them how to keep their hair in the best way, to use the conditioner every time, and to detangle when the hair is dry, if it's Caucasian, or when it's wet, if it's African American. I try to explain how to prevent damage.
Any other tricks, Dr. Cotterill?
Well, we often talk about camouflage techniques. If they have dark hair, they may want to color it lighter, so there's less contrast between light hair and light skin. Or they may want to perm their hair to give it more body. Something we haven't talked about, which is becoming more in vogue, is scalp micropigmentation. Some patients are doing that to color the scalp to the hair. If done discreetly, can work nicely. There's also hair fibers and colored hair fibers and powders that you can apply to the scalp to color it to your hair to give you more to give you the appearance of more volume and less see-through. So those are things I might touch on with the patient.
Yeah, great tips. Dr. Rogers?
Yeah, and just explaining the difference between these hair thickening products, like the shampoos and the conditioners. You know, they have, they're marketed for hair, sometimes they're marketed for hair growth, but you have to explain the difference so that patients, you know, understand that the minoxidil will make the hair grow, but it's the keratin, hydrolyzed wheat protein, hydrolyzed keratin, silicone derivatives, dimethicone, trimethicone, those are the things that actually coat the hair shaft and just make it instantly look thicker and fuller, but they only last until the next shampoo.
Oh, that's great advice.
Also, I tell them not to have a keratin treatment because
yes.
I've seen very bad telogen effluvium after keratin treatment and, you know, contact dermatitis, because a lot of now they change the name. So they say it's not a keratin treatment, it has no formaldehyde. Instead, they are all the same for the moment.
And flat irons too.
Yes.
Those are very damaging.
Yes.
Sometimes I talk about a hair diet, you know, for the patients who are coloring and then highlighting and then blow drying and then flat iron and then curling it. Like I said, that's too much. You got to give something else. Put your hair on a diet. And so, so that's my little trick.
Yeah, I like it.
I want to also address Dr. Williams. He is asking, is anyone, Dr. Tosti, I will start with you, know anything about using Botox for scalp hyperhidrosis that has then shown to help the hair growth? This is not something I'm unfamiliar with.
I cannot answer this question.
Oh, okay.
No.
I've not done Botox to the scalp myself. So I don't have experience with that, I'm afraid to say. Dr. Williams, I'm sorry, we don't have the answer for that one. So I'm so glad that we're keeping people's interest, and I hope that that we'll do this again soon. The ISHRS does have plans to continue with more live streaming for our consumers, and you can go to ishrs.org/livestream, and you can sign up to be notified for future events like this one. This viewing tonight will also be available on YouTube. So if you missed it or you had friends that missed it, it is going to be viewable in the future. Will be posted. We invite you to follow us on social media, and we're so glad to have your attention. We're so thankful Dr. Tosti blessed us with her wisdom and all her years of experience. And thank you, Dr. Cotterill and Dr. Rogers, for making the conversation so lively and joining me tonight.
Thank you.
Thank you. Bye-bye to everybody.
Bye.
Bye-bye.
Bye.